Yeah, good evening, everyone, for those in the US, and good morning for those in Australia, and good late evening for those in Europe. And well, I'm always impressed when those from Asia join us, as it's about 4 a.m. in the morning there. So very nice to have you with us. Today's session, we're doing something just a little different. We recently had a big meeting called SpineWeek in Australia, which is a meeting of multiple spine societies, including AO Spine, Spine Society of Australia, NAS had a section there, Indian Spine Society, Asia Pacific Spine Society, ESMIS, and others. And I was lucky enough to go to that meeting. I know that Australia is a long way away and not everyone can get there for it. So actually, over the next few sessions I do, I've picked some of the talks that I was able to go to, and I certainly wasn't able to go to everything. It's a meeting running with 5 rooms concurrently, but picked some of the talks that I felt were really of good value. And as you probably know from presentations at meetings yourself, often at these big meetings are pretty crowded. You get about 7 minutes to talk and 2 minutes for questions, and then everything just rolls on to the next section, which is great for getting multiple people through their presentations. But sometimes it's nice to expand on these things a little bit. And so today I have kept a fairly local flavor. These colleagues presenting is Tyra Lange and Dr. Y.H. Yao. Now, these are both colleagues from Adelaide, South Australia, where I'm based. We're going to have Dr. Yao talking first about his subject for SpineWeek. But I encourage, as always, people to ask questions on the text box, and I will put them through. We've got a few faculty with us today that may also chime in at any stage. So, and at the end, we'll have some reasonable time for discussion, which I think will add a bit of value. So I will introduce Dr. Yao to you. He's here, and I'll get him to start loading up his presentation while I give a little spiel about him. But YH has actually tolerated me for a very long time. He was my fellowship supervisor in 2010 and tried to beat a number of orthopedic bad habits out of me, being a neurosurgical spine surgeon. Taught me the mastery of repair of the dura, which fortunately I don't have to do too much, but still every now and again. But he's taught me a lot about learning and life, and a valuable mentor and colleague along the way. We worked together in one of our private clinics here, and this was a talk I thought was one of the highlights of ESMIS. So I'll introduce YH and get him to get going. Thank you.
Thank you very much, Dr. Selby, and welcome everyone. Pleased to share the topic that I presented recently, which is neuromuscular dysfunction in low back pain. So this was a presentation done on behalf of ESMIS as part of SpineWeek earlier in the month, and I will say that some of the slides towards the end of the presentation are from those that I have done for Mainstay Medical in the past. So neuromuscular dysfunction in low back pain, what is it that we're looking at? What is the issue? Well, the issue is that people present to us with similar looking scans, but they present with different levels of pain or different levels of impairment. And it's trying to correlate that and understand why what we see on the scans and the structure doesn't match what we are seeing in terms of function. So first of all, pain. How to define pain? Well, pain with the IASP, or the International Association for the Study of Pain, as you may know, is an unpleasant sensory and emotional experience that's associated or resembling that's associated with actual potential tissue damage. And not complicating matters further, but the more recent definition adds a few parameters to it. You don't need to look through this, but just top line is pain is a personal experience, multiple factors, and third line that is shaped through people's life experience. Show an example here. I'm choosing something that is a patient treated in conjunction with Dr. Selby, is this man who is in his late 50s. And he's had lifelong systemic steroids for his inflammatory bowel disease. And that's caused these osteoporotic collapses in his vertebrae. So he stands and walks uncomfortably and has a lot of pain. To get a closer picture, you see that he's got these sort of fixed collapsed vertebrae, and that's the way it's healed. So he has a rigid deformity and kyphosis. So structurally, if you look at that, that's very abnormal on the scan, on the x-rays. So if you treat the structure, like with an operation, which is what he underwent, and this is the second stage of the surgery with him in the top picture lying prone face down with that obvious gibbous hump, And then at the end of the procedure, some hours, with the operation, we see that we flatten off to a better appearing shape. And so starting off like this with a very true structural deformity, and with expertise guided by Dr. Selby in this deformity correction, we achieve this at the end, looking at front and side. So with that, we think, well, structurally, we've improved him. Is he better? And the answer is he is. He is standing much more straight. He's got rid of that deformity, and his pain levels after recovering from surgery are much improved, and his function is improved instead of walking around hunched forward like that. So that's an example here, but if we switch to something else, this is another scan of a different patient, a younger patient in his 30s who has an obvious L5-S1 disc degenerative process there. And you say, well, what's his function? Is he also impaired? Has he a lot of back pain? Has he got inability to work? What medications that he might be on? That scan belongs to Matt, who was our strength and conditioning specialist. So from him, function is not an issue. So he does his double body weight deadlifts, he trains others, he recuperates other patients and high-level athletes. But the thing about it is that his scan looks and his function does not match. So this is the structure or the form versus function. So what something appears and what it actually does is not an area that we can say directly correlates. And that's when we talk about function as a neuromuscular dysfunction, when that's not working. So I'll take you aside very briefly here and just refer to a study back in the United Kingdom called Physical Capability in Midlife and Survival. And it was over a many-year follow-up, a British birth cohort study. What this study was, back in 1946, over 5,000 singleton births were looked at and surveyed, and they were followed up through lifetime. And in 1999, when these individuals were age 53, almost 3,000 of them were contacted or contactable and undertook physical capability tests. And these tests included a few things that I'll show you, but they reviewed these patients 13 years later, these people. And unfortunately, at age 53, 13 years later, some people had died of various causes. The physical tests were the grip strength with a dynamometer, the chair rise time, which is the averaged out time from sitting to standing, and the standing balance time. So the standing balance time is like this. People were asked to stand up and hands on hips and on one foot. A little bit difficult with us all seated here, but feel free to try it yourselves. We did that in our meeting last time in SpineWeek, and the key thing about it was done with your eyes closed. So with your foot, as soon as your foot shifts and your other leg plants down the ground, that's the end of the time that you've managed to stand for. So looking at those three physical capability tests and surveying them back again 13 years later, looking for all-cause mortality, they found that all these factors, the people who had died from whatever cause, performed on average more poor compared to those who survived in all three dimensions, but in particular was standing balance time that showed a bit more correlation. And they said that if you could stand there and with your eyes closed and you didn't last 2 seconds compared to the group that were lasting over 10 seconds, then they found that there was 3 times more all-cause mortality in that group. It's quite significant. And that's not just from falls that you expect, but from all kinds of disease. So we have a look at this very general basic diagram that our CNS, our central nervous system, is giving signals to activate the muscles, which then act on the skeleton, the spine, the body. And then the feedback that comes back to tell it and say, this is what you've asked us to do, and this is what we've done. Is it correct? Is the position where we are right in space and time? And that's our overall neuromuscular feedback loop. So therefore, if that neuromuscular control is there, what is it that's depending on? Well, in part, if you did try to stand up there or you do it later, we're testing our proprioception. We're looking at how the muscles contract and accelerate. We'll look at kinesthesia, dynamic stability, preparatory and reactive muscle contraction. So when you prepare to stand on one leg through your past experience, you know this is what I need to do, what muscles to contract, in what order, in order to achieve that. And then you do that, and then the muscles contract, and the feedback is the reactive muscle contraction. So the feed forward and the feed back. And that involves conscious and unconscious movement patterns to try to adjust. So if that neuromuscular control were a dysfunction, it wasn't working, can you restore that? Can you bring that back to something more normal? Well, these are the factors that are key in maintaining good neuromuscular control. So perhaps, yes, you can undertake some exercises, and over time, you will see that you can improve on your balance, improve on those neuromuscular control mechanisms. As I say, it can go advanced as this. But what I like to show then is that many decades ago, this was also looked at as the spine as a whole system. And the whole system meant, just split very simply, it was described on the bottom left as a passive subsystem. That's your spine, your discs, your vertebrae, your facet joints, the structure and skeleton. On the bottom right, your spinal muscles around it were supporting, activating, and moving it, and all controlled higher up by the neural or nervous system with feedback. And the idea was that the spinal stability system was an interplay between all this. And if one of them were failing in some form, the others would compensate. And if it couldn't, then it would manifest in some condition or pain. And that moves me on to the muscles part of it for the spine. So for those of you familiar with restorative therapy, you'll know this. But otherwise, when we look at our scans, we look a lot at the discs and the facet joints. But attention should also be paid at the cross-section views looking at the multifidus. So multifidus, you know, as one of the primary core muscles, spans several vertebrae and considered the primary stabilizer of the lumbar spine. It's quite involuntary in its work. For those who don't have any problems, it's working well coordinated. It provides feedback, proprioception back to say where we are with the spine in space. And on the diagrams on the right, the axial MRI, you can see the multifidus changing from top, middle, and to bottom where there's more fat infiltration, suggesting maybe inactivation of that muscle over time. So in terms of how do you address this? Well, exercise can help to much a degree, as we've shown, but for the spine, the back specifically, can you target the multifidus directly? The answer is not easily. And then the thinking was, could you stimulate the nerves that make the muscle contract? So Reactivate is the name of a particular peripheral neurostimulation device that we have experience in. And this is what it looks like once implanted. So it's a peripheral stimulator with the leads that are not in on the spinal cord like a spinal cord stimulator. It is placed aiming for the transverse processes to stimulate the medial branch of the primary dorsal rami. And at this level, it will be the L2 coming over L3 transverse process. And the IPG, or the implantable pulse generator, is a battery much like any other cord stimulator device. And what happens is that the patient controls the therapy. It's not on all the time. They turn it on, they're lying down, and it activates for 30 minutes in the daytime morning, and then 30 minutes again at night as their protocol. And each time it will contract tonically for 10 seconds, relax 20 seconds. And the idea here is that over time, not really just strengthening the muscle, but more stimulating, activating it, and then try to trigger that feedback loop. So the brain starts to recognize and remember what multifidus is doing there, and then seeing over time. And restorative therapy means over time, whether we achieve some improvement in function and hopefully reduction in pain. And the studies that have been done on it over many years, one of them is called the Reactivate-B trial, is this one here, where they implanted 204 individuals with chronic low back pain over many years with high pain scores and disability on the ODI. And the left graph there shows that some did not have the system switched on as the sham group, but then they crossed over. So initially in the first little while, everyone seemed to drop their pain score like a placebo effect. But then the sham group was starting to revert back. And as they crossed over, the rest then showed this line where over 1 year, 2 years, and 3 years of using the device, there appeared to be an improvement. The other parameters looked at were, of course, the ODI. So on the graph on the left is the low back pain visual analog score, quite high average, 7.3 in the cohort that started at baseline of those 204 individuals, and then dropping by 1 year down to about 3 VAS for the low back pain, and sustained over that first 3 years and now 4 years on that study. And then the ODI, almost close to severe disability at 39 ODI, had dropped down to about 19, and then gradually down and maintained over the 2 and 3 years with using the device. So I've added a couple of figures on the top there in bold, and these reflect our sort of more real world experience, combination of the numbers that both myself, Dr. Selby have implanted here in South Australia. So in our cohort, we don't quite have as long as follow-up just yet. We had a slightly less high VAS starting, and they dropped down at 1 year to 3.3. And then on the right, the ODI seemed to be the same at 39, quite disabled, and dropping to not quite as low as on the trial figures, but about 21. And we'll wait and see as we gather more data on the year 2, year 3 into the future. Point to make is that our cohort are slightly older. They're about 10, 15 years older than the average age of mid-40s or early 40s in the study. So I'm going to round off with a patient here who is a couple of years after a discectomy for disc protrusion and leg pain. And just a point to say here, FDA is specific for implanting this device in those who have not had spinal surgery in the past. Here in Australia, we can. And this male here, a couple of years later, his main problem is back pain, not neuropathic leg pain. So here, you look at the scan, he's got a bit of a residual disc, but not any leg pain on the cross-section L5-S1. The rest of the discs look relatively healthy. He's undertaken conservative management with a lot of exercise and so on. He tries to avoid medication. He tries to continue to work as a paramedic. If we look at the next slide here, this is an axial at the higher level at L3-4, and looking at the right picture, the axial looks at its muscle. So the middle group is your multifidus as we go along to longissimus, and ilicostalis as we go out to the peripheries. But the key one is the central group. At the L4-5 level, maybe a little bit of fat infiltration. And at the L5-S1 level, back to beginning, you can see a bit more white as the area of surgery, and probably the area of more degenerate disc is showing inactivation muscle over time and changes on the MRI a couple of years later, a little bit more lower down. So here, you know, if people were to have paused to think, what would you do in your practice? And a normal working person, 42 years old, has now got this persistent pain. We also did a bone scan, a bone SPECT scan, and the select pictures show that there's a little bit of increased metabolic activity at the L5-S1 disc, and slightly more on that right side where you had the disc protrusion in the past. But the rest of the discs are not highlighting much. So yes, in your practice, were you to proceed past conservative management and the patient is disabled by it, would you offer them some form of fusion surgery or motion preserving surgery? Well, in this case, put in a reactivate. And so that's what the leads look like as it was on the diagram before. And so as he appropriately attended the sessions to activate the system twice a day and was diligent in that, we followed him up. And so preoperatively, his ODI scoring at 38%, quite disabled, and his pain score for the back itself was 7 out of 10. And 6 weeks, already the visual analog score seemed to drop, but really it's about 3 months onwards that we see the true restorative therapy showing its signs of improvement. And 6 months, and he is actually at 12 months on with a similar score to 6 months. So reduce both ODI and VAS, not entirely free of his disability, back pain, but he was improving his range of lumbar spine movements as we measure on the V-Move inertia measurement devices. He's driving his motor vehicle and work vehicle for longer distances with less discomfort. And one thing that he did always stop in his exercise before was the seizing up of his back that limited his exercise therapy. And now he was able to do that. And that's one example. I'll summarize for our discussions. So what I wanted to present there with neuromuscular dysfunction, low back pain, is that when we look at structural form and function, our scans, our pictures, and what the person can and cannot do, and the levels of pain, we don't always see a direct correlation. We would like to look at the spine as a whole, not just look at where the discs and the facets, but the whole system, the muscle system and the nervous control, the interplay and the feedback loops are important in managing the function of the body and spine. Of course, the person as a whole, not just the spine, particularly where pain is concerned. And so the neuromuscular dysfunction might be the so-called non-specific part of what we used to call non-specific chronic low back pain, where there may be not much else to do structurally, but they still are suffering. And the example device that I showed there, restorative neurostimulation, does show some promise as a management of this aspect of pain. I thank you.
Thank you, Wage. That was fantastic. And I'd like seeing that again, because when I saw it the first time, it just reminds us of so many concepts that we kind of know about, but there's still a lot of unknowns here. We do have Ali Baj has joined us, a few other faculty members. I don't have any questions on the chat box. I think this is an area as spine surgeons, we are still getting our heads around in many ways. And, you know, as you mentioned, I implant this device, you implant this device. I think we've both had a healthy skepticism for company-sponsored randomized trials, and I think their data is very convincing. I think, you know, when we've put it into our own practices here, it's been good to prospectively collect data to see if it is similar or not. And I think it's been encouraging that we have got fairly good results. And certainly not every patient benefits. And I think as we go on with time, one important thing that we have to do is some subgroup analyses to work out what are the pre-procedural factors that make this work versus, you know, perhaps the RCT selection trial data. Do you have any comment on that from your experience with it?
Yeah, indeed. I think our experience between us is that, well, first thing I said is our group is older. It's an older age group. And I think when people, and the average group, average age was about 42, I think, for the trial there. And doing what we did is good because it's showing real world data. And the reason probably is this concept of implanting a device. So you're younger, you may not be so accepting in a trial, you're more prepared for trying all sorts of new technology. But by doing so, you know, probably my first implant was in a much older patient. And yet we managed to achieve some kind of function improvement, being a more straighter way that they're walking, as opposed to any major drop in the rest of their disability. But you're right, we need to start looking in on that and say, why are some doing exceptionally well? And at this stage, the way that we follow up our patients between ourselves is that I'm seeing the majority coming back, both my own patients and Dr. Selby. So that's a good thing, because you're choosing your patients individually, and you've had some really quite remarkable improvements. And it's not, you know, it's not just I've had the device and something's improved me, but their function matches. You've got some young, high-level sort of athletes returning to sport. You've got people who have managed to get back to heavy-duty work that weren't before. But at the moment, initially, I thought it was definitely the younger group that were responding. But there are some that are a little later in age. But I think once you go beyond the 60s and so on, where other health factors are in play, other joint problems in play, we don't quite see the same drop in ODI. But other parameters to measure do show that these people are responding some way. They just managed to do one or two functions in life that are things they couldn't achieve before. Sorry, Mike, you're muted.
Thanks. Sorry, Wage. Matthew Birdchuck, a regular contributor, written on the chat box, is age-related atrophy of the multifidus normal? I think we can probably chime in on that, but I'll let you go.
Yeah, well, yeah, indeed. So age-related sarcopenia of the whole body, I think, is a pretty expected thing, and of course that's one of the parameters as to, you know, our future health and our fitness in life is to measure these things. If we were to scan everybody, the answer is yes, you're more likely to see fatty infiltration of it based on age. But the ones that we're looking at, for example, at 42-year-old, whether he had discectomy or not, we do see that sometimes, very early age, a lack of that multifidus and atrophy. And so the theory here is that something earlier has happened in life, and it's like back pain or whatever cause has caused an inhibition and then the muscle doesn't contract, and then it starts showing it. The one thing that we would be very interested in is to see what happens to the muscle after the person's had a period of reactivate implantation. And the limitation to that is that whilst the device is similar to other core stimulation devices and should be MRI conditional, the company is yet to provide us with that defined conditionality so that we can go on and research and scan these people a few years later and see what happens. My feeling is that it probably will still look like what it looked like at the start. It's just the function's changed.
Yeah, I mean, to Matthew's comment, it's rare that I see an older patient with severe back pain with a good multifidus. I'd encourage us all to look in our clinic for them. I mean, they're out there are a few of them, but often it's just completely wasted. And I think, we know that there's a huge incidence of asymptomatic changes. There are studies on CT abdomens of degenerative scoliosis in people over the age of 80, showing a 20% prevalence. Yet not all those patients have back pain. So I think we always have to look at the multifidus and that whole muscle control envelope. It's very important. One more question from Matthew was, the MedX or comment MedX spinal rehab equipment was designed to isolate and strengthen the multifidus. And I think, that's probably a good point as to, and the other thing about this device is mechanism of action. And this is something that's been discussed a bit as to whether there is actually a neuromodulation component to it as well as a pure functional restorative component. And that's up for debate as well. I'm not certain of that, but there may well be in some patients just this local feedback loop of helping with how you receive pain signals, but that's still not really defined. The device wasn't designed for that, but those doing it for a while seem to believe there may be something to that argument. I don't know what your thoughts are on that, Wage.
Yeah, I agree. As with you at the beginning of this device, we weren't part of the trial B. We weren't part of the initial development and so on. So yes, when we looked at it, say, how's that going to work? And it can't be as simple as just strengthening a muscle. So we already knew at the beginning it's some sort of feedback loop thing that's going on. In terms of neuromodulation and changing pain signals, it is only turned on for 30 minutes in the morning, 30 minutes at night. A little bit different from core stimulation where, usually it's on all the time. That's one thing. But maybe it is just like everything. It's the brain knowing that that muscle's contracting and how it's contracting. So it's, a bit like when we exercise and we tap that group of muscles with the trainers, we know that's the one we should be contracting. So maybe just a very strong, obvious way of doing that and just getting the whole system working more coordinated again.
Excellent. Thank you so much, Wage. Very much appreciated. If there are any more questions, I can sort of answer them as we go, but if you've got a research meeting to go to, you can certainly jump off if you want. And I'm going to introduce Tyra Lange, who's a brilliant engineer, a biomedical engineer, again, keeping a local flavor. She's from Adelaide in South Australia, working at Flinders University. Tyra, she's part of Flinders University Medical Device Research Institute. She has honors and she's a current PhD candidate. And Tyra, I'm correct in saying this is some of your PhD work, isn't it?
Yes, it is.
And I think this is just generally speaking a platform where we should be promoting young researchers. We go to the meetings and people get 8 minutes to present really a lifetime of work, which is pretty tough. So hopefully Tyra can expand a little on her talk today. And Tyra, if you want to start sharing your screen,
yeah,
it works, and we'll go on with it.
So hopefully you can all see that now.
Working well.
Okay, thank you very much, Mike, and thank you for having me. So I'm a PhD candidate at Flinders University, and I'm super excited to share with you today my research, which is titled Biomarkers of Breach, a biomechanical investigation of the acoustic and torsional characteristics of cortical wall perforations. So this was part of a talk that I gave at SpineWeek. So all the authors declare that they have no competing interests. Freehand pedicle screw insertion has been performed since the early 1970s, as we know. Today, in an ever-intensifying marriage of medicine and machine, numerous intelligent navigation systems are proposed for accurate pedicle screw implantation. It is, however, the opinions of many healthcare professionals that as technology progresses, it is important not to lose the art of freehand pedicle screw placement and rely solely on these new technologies. Freehand screw insertion is performed without intraoperative image guidance. Thus, the procedure is heavily reliant on intricate knowledge of vertebral landmarks in conjunction with sense perception. So one such example of these sensory perceptions is auditory feedback. During pilot hole drilling, friction between the drill bit and the bone creates distinct audible vibration patterns picked up by ears, which can be used to deduce whether the bit has perforated cortical walls. Another example is tactile feedback, which is the feeling of torque in the hands, which can also be used to determine whether screws have reached the cortical bone. So this study aimed to quantify these auditory and tactile cues, which aid surgeons in assiduous attempts to circumvent iatrogenic cortical breach. And it furthermore aimed to confirm that high amplitude acoustic emission and insertion torque are directly correlated to cortical breach. So in vitro experimental testing was conducted on 18 fresh frozen ovine femora. Prior to use, the extraneous soft tissues were resected and these specimens were subdivided to allow a total of 54 individual insertions to be investigated. Pilot holes were then drilled into the bones utilizing a whole power pro drill and a 4.5 millimeter drill bit. And the acoustic emission or the drilling sounds were captured at 48 kilohertz by custom sound sensor module. A laser beam timer was then implemented to detect the time of far cortex breach. So this setup for bicortical drilling allowed the exact time the drill bit plunged through the far cortex to be breaking the beam to be determined, which was denoted by T laser or time laser. And as such, the auditory feedback could be quantified. So these two images are the typical acoustic response curves in the time domain. And it's postulated that these two high amplitude acoustic emission events correspond to the dense cortical walls, this being the first wall and this being the second wall. So the time at the second acoustic emission local maxima was recorded, and this should be the time of far cortex breach. Subsequently, the distance between the inner cortical walls was measured and termed D walls, and the thickness of both the first and second cortical walls were also measured, and an average cortical thickness was calculated from that. Pedicle screws were then inserted at 6 RPM following the pre-drilled trajectories utilizing the specialized mechanical system alongside. And throughout this insertion, the screw depth and torque were digitally captured at 20 hertz. And as such, the tactile feedback could be quantified. So it's hypothesized again that these torque peaks, insertion torque peaks, are the dense cortical walls. We see the first wall and the second wall. The distance between these insertion torque peaks was then calculated and termed D peaks. So data regarding the time at acoustic emission local maxima and the time of laser break were collated, and Pearson's coefficient signaled a significant strong positive relationship. When we looked at the means, two sample t-tests revealed that there was no statistically significant difference between the time at maximum acoustic emission and the time of laser break. The observed effect size was small, indicating that the magnitude of difference between these averages was minor, and the population means are assumed to be equal. Therefore, high amplitude acoustic emission is directly correlated to cortical breach. Data regarding the distance between the screw insertion torque peaks and the distance between the cortical walls was then collated, and Pearson's coefficient signaled a significant strong positive correlation again. When we looked at the means, a two-sample t-test revealed that there was no statistically significant difference in the distance between the torque peaks and the distance between the cortical walls. The observed effect size was again small, and the population means are assumed to be equal. So therefore, high amplitude insertion torque is directly correlated to cortical breach. We also wanted to explore the effect of cortical thickness on insertion torque, and evident was a significant medium positive relationship between the maximum insertion torque and the average cortical thickness. We then wanted to explore the effect of cortical thickness on the acoustic emission biomarker, and evident was a significant small negative relationship between the maximum acoustic emission and the average cortical thickness. So high amplitude acoustic emission and insertion torque occur at the moment of cortical wall perforation. Thus, they can be used to accurately detect or diagnose breach. These biomarkers of breach have been identified in the literature many times, but they've not been confirmed in this way. And the acoustic emission has not yet been extensively investigated. In conclusion, strong signal variations are provoked by changes in local tissue properties, such as density and microarchitecture, and this facilitates the rapid detection of different material environments. Both the maximum insertion torque and acoustic emission were significantly affected by cortical thickness, but further exploration is needed. So the ability to recognize various bone states is valuable when drilling and screwing in the vertebrae. And using the acoustic emission and insertion torque parameters, continuous monitoring routinely performed by surgeons via haptic and auditory perception may possibly be supplemented by advanced tool sensing. So this may be particularly important in modern robotic systems where the rigid arms provide steadier control. However, they can currently reduce or distort these tactile and auditory cues as they introduce additional vibratory and mechanical feedback. So an obvious limitation of our study is that this was done in surrogate bone in sheep femora, but we are progressing this into ovine vertebrae and then cadaveric. And we're seeing very promising results that breached and non-breached trajectories do feel and sound differently, which is very exciting. We're also looking into the classification and prediction of these breach events using AI. And at SpineWeek, there was some really interesting talks from a research group out of the US about the pedicle preparation and screw insertion under power, moving towards that. And another group from Korea who noted that the next step in navigation is the robotic use of drills according to segmentation goals, automated screw planning, and bone drilling. So this is really exciting because we believe that our research falls within this ambit, and that signal processing based approaches such as cortex detection algorithms for breakthrough avoidance may act as safety nets for patients and may improve the acceptance of new autonomous navigation systems. Thank you very much.
Tyra, thank you. That was brilliant. I think we haven't got any questions from the chat box yet. I think you've sort of blown everyone away a bit with what you've done. But the important thing to me here is the application of this going forward. And you've got to do the basic research which you've been doing to prove that. We've got to thank you from Dr. Leonardo Soto. And look, I think the application to me here is potentially, as you mentioned, robotics. We've got a few of the faculty here, a few of the surgeons on have probably tried robotics. And one of the huge issues with the early variation of robotics was that you meant to trust this thing, but the drill would skive. And so the drill would bounce off either the edge of the facet or the transverse process, and then it would skive. And then, you don't get as much tactile feedback as a surgeon through a drill tip generally than you do by hand instruments. So I do see applications in that. And I think it's about, I'll ask you how close, because I've seen your setup, how close are you to getting this, small enough to fit into navigation systems?
So we've got a really cool setup, like a micromechanical device at the moment, which is really cool. It sort of turns at a low RPM, so it's not specifically for the drilling just yet, but definitely for insertion of screws under power. And we're getting really good results. So we still have to confirm that we can use these different biomarkers or different signal processing based approaches in these different intelligent systems. So we're currently breaching a whole lot of bone and just confirming all different sorts of things. But yeah, there's been discussions with different research groups and University of Sydney to look at some different stuff, which is exciting.
I mean, I know you've raised the issue and know about it, but I'm always amazed by that study they did, which showed that experienced consultants could only detect 2/3 of breaches, if that. And I think that's a fascinating study. And I think, we all think we're pretty good at these things, and whether those breaches were clinically significant or not is up for debate, I suppose, in some respects. But we are heading towards a world where I think pedicle screw breaches are not really going to be acceptable. People are going to get sued, and
Well, obviously, if
Yeah,
there's automated insertion, it would obviously drive massive changes in legislation and that sort of thing. So it would be interesting to see.
sorry, just a plane going overhead here. Okay, so we've got yeah. Is there, I'll just see, is there anyone with any more questions at the moment for Tyra? No. We're not getting nothing else from the chat box. You've blown everyone away. That's brilliant. Look, I would like to thank Tyra and YH for coming on today. It's been a great session. I'm not sure who's on next week. I know for my next session, I'm going to also present on the Spine Society of Australia best papers. Might have to have Tyra's group back again, but
We'd love to.
I thank you for coming on, because I think we try to really flick around a bit during this meeting and focus on a whole bunch of different things. And we've probably been a bit short on the biomechanics and more basic science part of what we do. That's actually probably the most important part in many ways. It proves our concepts going forward. So thank you so much. And we'll log off now and see everyone next week. Thank you.